Small intestinal bacterial overgrowth historically occurred in patients with altered anatomy, like strictures or post-surgical changes, but today we see it functionally in motility disorders and chronic dysbiosis. The gold standard definition is greater than 10 to the fifth power CFUs per milliliters of jejunal fluid. This overgrowth of bacteria shifts fermentation into the small intestine, where really fermentation should not happen. This leads to symptoms of bloating, gas, heartburn, diarrhea, or constipation. This is showing the different intestinal microflora and where they can exist. And it's important to note that SIBO can manifest with a variety of symptoms and is often misdiagnosed as IBS. Up to 75% of IBS patients may actually have SIBO. And this connection has dramatically shifted how we evaluate patients with chronic bloating or constipation. It's also important to note that SIBO is often a symptom of an underlying gastrointestinal condition. We can think about ways that our body normally prevents this process from happening through several different mechanisms. Our body prevents overgrowth of bacteria via gastric acid, which kills bacteria before they enter into the intestine, pancreatic enzymes, which secrete certain antimicrobials, motility, especially the migrating motor complex, which sweeps bacteria down in the small intestine between meals, our ileocecal valve integrity, which prevents any retrograde movement of bacteria, and gut immunity, which contains bacterial populations. If any of these or multiple of these systems start to fail, our risk for SIBO can increase. Bacterial adherence to the mucosa can create direct tissue injury and inflammatory signaling. The microbiome shifts and the immune system then becomes activated. Over time, this can lead to destruction of tissue and nutrient malabsorption, inflammation locally, increased permeability, and further dysbiosis. So SIBO is not just about gas, it is about intestinal injury. SIBO can also affect nutrient absorption because bacteria begin using nutrients before the host can actually absorb them. This can cause B12 deficiency, fat malabsorption, and altered concentrations of fat-soluble vitamins. Interestingly, vitamin K and folate may be normal or even elevated due to bacterial synthesis. Clinically, patients often report fatigue, neuropathy, and symptoms that mimic IBS, but the root cause or a contributing factor could be bacterial overgrowth. This is just showing that SIBO is not localized to just one area. Mucosal injury can lead to widespread interference with digestion and absorption, and patients often come in frustrated because they've tried elimination diets, probiotics, antacids, fiber, or digestive supplements, but symptoms still persist. If motility is impaired or bacteria are overgrown in the wrong place, dietary changes alone won't often fix that problem. Identifying the overgrowth is really essential before attempting treatment. So here we can see a combination of direct and indirect effects. Symptoms often include bloating, distension, abdominal cramping, diarrhea, and even sometimes constipation if methane-producing organisms dominate. Nutrient deficiencies are common, especially vitamin B12 deficiency, since bacteria compete for cobalamin. Fat-soluble bacteria or fat-soluble vitamin deficiencies can also occur, vitamins A, D, E, and K, due to bile salt deconjugation. And this is why SIBO could masquerade or can approach or appear with other conditions, such as malabsorption symptoms or even IBS. Now, as we move towards the diagnostic testing component, we have to understand how SIBO affects the gut and how it affects nutrient status, which we've looked at. And so now we're going to look at how breath testing helps us localize where fermentation is occurring and whether bacterial activity is present in the small intestine. We could see, let's see here. Looking at this slide, you can see the breath test results from healthy controls here and patients with IBS symptoms here. So our patients with IBS symptoms show earlier, more pronounced hydrogen elevation, and historically IBS was considered a diagnosis of exclusion. It still is, But with breath testing, we know that a significant portion of IBS patients also have concomitant SIBO. And so identifying this can shift the treatment from just symptomatic management or symptom suppression to trying to potentially address the root cause. The gold standard of kind of SIBO testing is jejunal aspirate and culture, but this requires endoscopy and specialized training. It's also prone to contamination from oropharyngeal bacteria during collection, and since it's invasive, expensive, and really not practical, we don't use it clinically. Because of these limitations, we have actually moved towards non-invasive breath testing as the primary method in outpatient settings. So the breath test looks for hydrogen and methane because humans do not produce these gases, bacteria do. About 14% of gas produced in the gut diffuses into the bloodstream and is exhaled. When fermentation occurs in the wrong location, like the proximal small intestine, we detect an early rise. It's a surrogate marker of bacterial overgrowth without needing any invasive sampling. Now typically I mentioned here, like there's this typical curve. Typically when you are looking at a curve, this is looking at a hydrogen production curve. And you see just a single production peak. This is kind of considered normal here in this individual. So you have this single fermentation peak that goes up and down occurring in the colon, which typically appears later. People with SIBO would often actually have an earlier rise, oftentimes within 60 minutes. And this is because fermenting carbohydrates in the small intestine happen before, and they really shouldn't occur there. So you see the rise happen before kind of this like 60-minute marker. This is considered like normal here. Normal rise and fall. This is much higher. We would typically expect to see this with SIBO occurring a lot earlier. But this would be obviously concerning because it's happening at the same time, but it's a greater result. Going back to then looking at our hydrogen methane breath test and kind of our concepts behind it and the procedure behind it, when we're collecting this test, a fasting baseline breath sample is required. You then administer 10 grams of a lactulose solution. So we're back to that lactulose solution. And then you collect breath samples every 15 minutes for 2 hours. I've had this done with patients in my clinic before. A prolonged gradual rise represents a normal colonic fermentation, but a sharp early rise of greater than 12 parts per million hydrogen or methane suggests SIBO. The key point is timing. Where the peak appears corresponds to when fermentation is happening. So again, looking at this slide, now knowing what we know, we can see this is looking at just hydrogen, not methane. We would expect a rise to occur around this 60-minute mark, and this is showing a normal rise and fall of our hydrogen gas. This is showing a rise and fall occurring at that 60-minute mark time, which is considered normal, but the rise is much greater. We can see it's greater than a 12 rise up to that 25. Now, if I was really diagnosing SIBO, I would like to see this rise occur a little bit earlier for me to be very solid in my diagnostic capabilities. But this is just showing the difference and how extreme you can see that gas production difference be. There are some important nuances to keep in mind. Early literature defined a positive test as a clear peak before the later colonic fermentation peak, which helps to differentiate between small intestinal fermentation and normal colonic fermentation. So you always want to interpret in the context of timing because an early peak will equal the small intestine versus a late peak equals the colon. And this temporal relationship makes the breath test remarkably useful in clinical practice. This slide is looking at, again, classic interpretation. A positive breath test is defined by an early hydrogen or methane peak, meaning measurable gas rise at least 15 minutes before the expected colonic fermentation peak. And because carbohydrates transition or transit to the colon and typically take longer to do so, an early spike indicates bacteria are fermenting in the small intestine, not just the colon. This reinforces in breath test, timing is everything. Timing of the rise is just as, if not more important than the magnitude. So early spikes, again, is what we're looking for. This is an example of a breath test device you can use, but it does not have to be this fancy. But there are some clinical breath test devices available. Samples here are collected through the mouthpiece and analyzed via spectrometry. And in most clinics, patients will just receive a test kit to take home or to complete in office over the 2 hour period. But the ease and non-invasive nature of this test has completely changed how we evaluate a functional GI disorder. When we come back, we'll look at celiac disease as kind of our last big testing thing to consider.